Hello, and welcome to today's product showcase. My name is Greg Leeson, and I'm a global product marketing manager at Laerdal. Approximately 6,500 newborn deaths occur every day, with the majority of them happening within the first week of life. The leading causes of death include birth complications like birth asphyxia, trauma, and neonatal infections. To help address these issues, we would like to introduce you to today's new babies to our portfolio, Emily and Emma. Both of them are full-term newborns that combine realism, lifelike anatomy with cutting-edge technology. Their goal is to help train healthcare professionals and their teams in neonatal care and enable realistic practice in resuscitation, stabilization, and critical care protocols. The goal, of course, is to bring the entire neonatal journey into the training room. We hope today we're going to show you a little introduction about them. We have a very special guest who's going to take us through a journey here and learn about their features. So I'd like to introduce Dr. Jens Schwind to the product showcase.
Hi, Greg. I'm very happy to be here and do this product showcase with you.
Thank you, and I really appreciate you finding time to join us and our audience here to teach us a little bit about them.
Because we are so proud about the new simulators.
Of course. So maybe we can start in your words. Can you tell us a little bit about them and what gap they're going to help fill in training?
As you already said, Emma and Emily are term baby simulators. So some of you might already know Paul, our preterm simulator. And of course, everything about Paul was about preterm stabilization. So Paul addressed a very special group of healthcare professionals, mainly, of course, neonatologists and high-end neonatal teams. But of course, neonatologists have to deal also with term babies. And most of the time, actually, they are healthy babies. But sometimes if we really have to or if we really have to resuscitate a term baby, even for us neonatologists, it's hard. And so we thought, okay, it makes sense after Paul to have a simulator that addresses this area of term baby resuscitation. And therefore, we developed Emma and Emily.
Perfect. And you mentioned Paul there. Maybe you can tell us, you've come on the show before and done a product showcase, Paul being our high fidelity premature simulator. What's changed with you and the team and life since then?
Yeah, of course, exciting times. Because in the meanwhile, after the last product showcase, we have been acquired. So Sim Characters has been acquired by Laerdal, is now part of Laerdal. And yeah, for us, for our entire team, it's super exciting to see how Laerdal brings Paul to all regions of the world, and now healthcare professionals in all regions in the world are able to train with Paul, and Paul can help to support their training sessions.
And you mentioned healthcare professionals around the world with Paul. Are those the same teams that would benefit from Emily and Emma? Are we talking the same groups?
As I already said, of course, Paul addressed a very special group of healthcare professionals, these high-end neonatologists mainly. But as I said, babies are born also in smaller hospitals. And so there are a lot of people who have to take care of newborns. So Emma and Emily definitely address neonatologists and neonatal teams, but also, of course, can be involved in the training of midwives, of obstetricians, anesthesiologists in the operating theater, transport teams, EMTs. So Emma and Emily definitely address more people. Yeah.
Perfect. Well, I'm really excited, and I hope you are, the audience today, excited. We're going to do a little tour of them, teach you about the features, how they can impact you, your simulation center, and your community. And yeah, thank you for joining us, and we're excited to show you them. Perfect, Jens. Let's get started here. And we have both Emily and Emma on the table here. And maybe we can start on their exterior and what we see here. Maybe you can tell us a little bit about them.
Yeah, of course. So we have Emma and Emily, and this was the idea to build or to develop two completely different simulators from the outer view. So we wanted to develop two different personalities. So as you can see, Emma is dark-skinned, Emily is light-skinned, but also the facial impression is different. So they are two different personalities. And for us, it's always important that our simulators always also reflect the people in our communities and reflect our patients. And so the internal core, the technical core of Emily and Emma is completely the same, but their outer appearance is different.
And maybe I'll just reiterate that. So they're technologically identical,
Yeah.
features, mechanics, software, and it's only the skin tone and the attention to details. Is that accurate?
Absolutely. So they are, for example, different hair. If we just take off her, you can also do so, Greg. It's
I'm
not
nervous,
something a doctor has to do. Also a father can do. So you see that they are different, but what you already see also is that they are breathing. And I love it because it looks so realistic. And that was the idea behind all the development.
And maybe we can talk a little bit about the names. And I would love it if you said you named them because my daughter is named Emma, but I know that's probably not the truth.
I'm sorry, Greg. It was not after your daughter.
But maybe you can tell us. Yeah,
maybe I can start with Emily. And as I already talked about when we talked about Paul, why was it Paul? And Paul was a preterm simulator, or is a preterm simulator. And Paul means the small one. And so we thought, that's the perfect name for, it's Latin, of course. And we thought it's the perfect name for a preterm simulator, the small one. And then we looked for a name for Emily, of course. And we thought, okay, what name makes sense? And I liked Emily as a name, and the team liked Emily. And then we looked it up, and Emily means the eager one. And so I think for a newborn simulator that brings us into a new era, it makes a lot of sense, the name. And so we said, okay, Emily makes sense. And Emma is a completely different story. And there is a story behind it. And this will be the cliffhanger for this product showcase. Do you know the movie 9 Days?
I've heard it, yeah.
You have to watch it. And if you watch it, you know why Emma is Emma.
Okay, so we've got a little bit of homework, everyone, here to watch the movie to understand their origins. So.
Yeah, and you will understand it for sure.
But I love it how their realism here, how you give their own names, because that's really important when we're trying to get engagement with our trainees and people using them to really believe that they're in a lifelike situation to get the most out of training, right?
Yeah, and better to connect them to the simulator.
Right.
Yeah. I don't know if you've ever been in a flight simulator. In a flight simulator, you immediately imagine, you believe that you are in an airplane or on an airplane. And this is what we always aim for simulators too, that people really believe they treat a real baby. Yeah, and that's for me the reason why realism is for me so important.
Right. Well, I'm really excited. And thanks for taking us a little bit on the outside, and excited to see what else they can show us. Okay, so audience, here we have Emily on the table. Just to let you know, we've moved Emma off, but we're going to bring her back. We're going to alternate them as we go through different segments and introduce the features to you. Also, just want to point out, neither Jens are wearing gloves, of course, and we're not dressed in a clinical or simulation setting. This, of course, is intended to give you a product overview and understand what they're able to do. So Jens, in any conversation I've had about newborn simulation, the first topic is always airways and breathing. So maybe you can tell us a little bit about Emily's airway.
So as airway management in newborns is key, in preterms like in term babies, the airway is super important for us. And already for Paul, we developed a super realistic airway. And for that, we used MRI scans of preterm babies of the airway of the skull, transferred the data to printable data, and printed the molds for the airway in 3D printing. And this, of course, resulted already in Paul in a super realistic airway. And the same is, of course, true for Emily. And in Emily and Emma again, we used MRI scans of term babies and again developed this airway in 3D printing. And I always show this first also in presentations because we are so proud about the realism of this airway. And maybe we can do so. We can intubate Emily.
Yeah.
And I will just stop her spontaneous breathing for a second. It would be great if you could assist me a little bit.
Of course.
I will not ventilate her. I will just jump into the intubation to show you the airway. And just a little detail. So if you look into Emily's mouth, you see, if you change the position of the head, that the tongue is moving. And if you move the head backwards, the tongue will fall backwards. And so like in a real baby, you have to push the tongue down. And now we can see with the video laryngoscope, you can see on the screen the airway. You saw the epiglottis popping in the view, so you see how flexible everything is. And if you could do me a favor and just hand me over the tube, and if we intubate her now, you see the tube going inside. Yeah. So if you give me the bag, this would be great. And maybe you can hold the tube here. Please hold it secure and just bag her a little bit, not too. Yeah, perfect. And what you can see, because in the meanwhile, I can explain a little bit what we see on the screen. And what you can see is that Emily is intubated. You can see that you bag her now. And what we also recognize immediately is that I was a little bit too excited about my intubation. So I ended up in the right main stem. That means that the left lung collapses automatically because there are sensors in the trachea, and only the right lung is ventilated. And what the trainees see, this is what the instructors, of course, see, and what the trainees see is that it's only the right chest that's moving. And hopefully the trainees will recognize that there is a problem. So please pull the tube a little bit back. We can see this on the screen. Yeah, the left lung automatically inflates, and what the trainees see is that now both chests move again. Yeah, so you can intubate, of course, orally. In a lot of European countries, we just stop the ventilation, and we'll just do the nasal intubation. So in most European countries, babies are intubated nasally. Both is, of course, possible. So we can place the tube and look for the tube in the airway so I can see the airway. And for this, of course, I need a McGill forceps, and I just take the tube and put it into the trachea, hold it, and maybe if you ventilate again, we can see now it's in the right position. And we can see that both lungs are moving, the chest is moving, and what you also can see, and we will talk a little bit later about this in detail, you can see that we measure the tidal volume. And green means, Greg,
I'm not so bad.
No, you're not so bad.
And I love how there's feedback on the screen, of course, for the instructor or the facilitator.
Yeah.
But as the trainee, of course, we're looking at the chest and we see that chest rise. It's incredibly
And as
powerful.
I said, airway management is so important. So we as trainers, as instructors, we need to see in detail what our trainees are doing.
Right.
Yeah. Yeah. We just take it out again.
Yeah. Maybe I can ask you another question about intubation in general. So one of the challenges I've often heard is that novel users might be scared to intubate because you're always worried about damaging. Maybe
Absolutely.
What's your philosophy on that or your thoughts?
This is an important question because durability and realism are difficult. You need to find the right balance. And we want trainees to train, because we don't want them to train on real babies. So they need to have a durable airway, but also a realistic airway. And of course, sometimes things happen. Yeah. And so it's in the end of the day, it's silicone and they might tear. Yeah. And so we enhanced a lot the durability of this airway. However, it can happen that somebody causes a tear in the airway. And this is definitely a problem because I do only in situ training sessions. So if a course is organized and the first trainee in this course, in a 3-day course, tears the airway, the simulator is down, of course, and you can't do the rest of the training. And so for us during the development, it was important to come up with a new idea. And the new idea was that Emily and Emma have airways the customer can replace on site. Yeah, it takes 10 to 15 minutes. You just take off the skin and you loosen some screws, and then you exchange the airway on site. And I think that's a real cool feature and a future-orientated feature because this will be helpful and will reduce downtimes of simulators.
Yeah, like what you just said, that's an incredible feature. We're talking about reduced downtime. Yeah. Tears do happen. We want our newer and novel users to practice on a simulator. We don't want them practicing, of course, on a live patient. Yeah. So that is quite an incredible feature. Of course, hopefully tears don't happen, but we know the truth, it does. So that's a very cool way to help our users out. So,
and of course it opens new options, because what we plan for Emily and Emma is to create a complete ecosystem around these simulators. And beside other congenital malformations like an omphalocele or gastroschisis, what we are about to develop for these simulators, you can also think about congenital malformations in the airway. And so you can exchange the airway depending on the case you're training. And this gives a lot of opportunities opportunities for the future.
Yeah, that's quite cool, right? We're talking about efficiency and downtime, but also clinical impact.
Absolutely.
So one incredible feature to different routes, how that can really change a simulation center and an experience. So, but yeah, thanks for sharing us a little about the Airway. I love it. I love the realism. The MRI scans are incredible. And of course, replaceable Airways is also too. But yeah, thanks for sharing that. And we'll see what's coming up next. Okay, Jens. So we brought Emma back to the stage here to continue our stories. In a previous segment, you talked about intubation and airway, but I know you've got the saying about that intubation and ventilations. Maybe you can elaborate a bit.
Yeah, of course. Everybody loves intubations because it's very hands-on, so we love intubations. But actually, ventilation skills are a lot more important than intubation skills. So everybody who's taking care for newborns needs to be able to ventilate a newborn. And so again, we put a lot of efforts in designing everything around this, also for Emma. So if we have a quick look for the software, you can see on this left here, you can see the large 3D animation, real-time animation of Emma. And so if I would ventilate her, I would at least place a saturation. And so if the trainees place a saturation, you just hover over this bubble here, click on the saturation icon, and that will bring up the saturation to all monitors.
So it's the idea that the trainees are obviously interacting with the simulator and you as a facilitator real time together.
And that was the idea to bring closer together what the trainees see and do and what the instructors see.
Right.
Yeah. Right. And so if the trainees attach an ECG, you scroll, or the instructors click over this bubble here, click on the ECG leads, and you will see also the ECG trace on all the monitors.
Right.
And we can have a quick look for a sensor. So I know never shake a baby, yeah. But if we move Emma a little bit, then you will see that the curve changes, and maybe we can do this for a second. So if we just lower the heart rate below 60, and the trainees would start chest compressions, you can see the thumbs on the screen,
right.
You can see the depth, you can see the frequency, and what you can also see is the artifacts in the monitor.
Right.
And this is a Draeger layout, and the Draeger monitor typically thinks this is a VF. Yeah.
Okay.
So it's not ours, but the Draeger believes, I can't interpret this curve. I think it's a VF.
Right.
It's not, of course, because we're doing chest compressions, and you see that the trace comes back again. Yeah. So this makes me a little bit nervous. So I will increase the heart rate again and also the saturation again. Yeah. And go back to the ventilations. So the idea behind the ventilations was, again, that we put a lot of efforts in developing this head position sensor. And if trainees, and I need to change this here a little bit to make it a little bit more comfortable for me, if the trainees hyperextend Emma's head, you can see, I always change between Emily and Emma. I'm aware of that, but it's like with the kids at home. Yeah, sometimes you're confused. So if the trainees hyperextend Emma's head, the instructors can see this on the screen, so they end up in this red area.
Okay.
And if the trainees now ventilate Emma, what happens is the belly is moving and the chest is moving. And like in a real baby, they now have to find the sweet spot. And as soon as they find the neutral position, the chest will move. And if you want to, you can just auscultate her, and you will hear the breathing or the ventilation sounds on the right side, and you see the stethoscope. By the way, all these events go directly into the integrated debriefing system. So you see the auscultation of the left lung, and you will hear on the right and the left. Of course, you will hear lung sounds. If you auscultate in the middle, you will hear heart sounds. If you like, you can do if you want.
Yeah.
I
love how the fact that, I could clearly hear it, but also as I moved it around, we saw on the interface where I was. Again, more feedback. So what the trainees are actually doing, the facilitator sees at the same time.
Yeah. And of course, as Emily is a high fidelity simulator, that means we can start a program. So if we start this distension program, click here on auto, what happens now is if the trainees now hyperextend Emily's head, instructors can see this. And if they now start to ventilate, again, the belly is moving, like before. But what they do now, and have to speed up a little bit, because in a real baby, in a term baby, this takes some time. But what you already recognize it, that the stomach fills with air. And if I go a little bit faster and with a little bit more pressure, I can speed up this process a little bit. I would not do this in reality, of course, But you see that the belly gets more and more distended, and finally it stops moving. So you're in the middle of a training scenario. You have a distended belly. You can drop the saturation, and the trainees will see that Emma, it's hard to see, of course, because of the dark skin, like in real babies with dark skin.
Right.
So Emma is getting a cyanotic. You can drop the heart rate, and hopefully somebody in the team will recognize that the stomach is the problem, will draw the air out.
Okay.
If they do so, you click on, or the instructors click on deflate. Air goes out, belly goes down.
So drop there.
We can normalize the saturation. We can, if they ventilate effectively now, of course.
Right.
You can increase the heart rate, and eventually Emma will also start breathing and maybe also moving and also crying. So the case is solved. And
so
we are very proud about that, because I love this, because it looks so natural. It's not always the same movement. You see, it starts slowly, and she moves more and more. And because it's an algorithm behind it, it's just by chance how she moves.
Right.
Yeah.
And you don't see the rhythmic movement of always happening on every second. I guess that's normal movement.
And so it looks more realistic.
And I think for trainees, we just went through a stomach distension scenario, high stress, to save the baby. And when you get to this moment, almost an instant relief that you've done it correctly, which is, of course, helping with engagement.
And you can hand over afterwards, hopefully, the baby to the mother, or in our case, to the father. So if you like to...
It's going to take me back to my early father days.
We'll cover her a little bit,
yes,
of course.
Please.
And what you feel is that you feel the spine movement. So you have to protect Emma's head. If you don't do so, the head will fall back. So you feel that she's you feel the muscle tone.
And she does feel, it feels like a wobbly baby, because that's how babies feel, and it's not just a solid block. It feels natural, feels exactly how a baby should. You mentioned the head. I'm just going to let it, again, I'm not supposed to do this, but I can see what you're talking about there. If you got to protect the neck, to prevent exactly that. So
absolutely.
I love it. So I'm going to give you back. No, but it's really interesting. We learn about all the incredible features that Emily and Emma have in this distension. It just shows you, again,
just about crying,
all the high fidelity features they have to make this an effective training tool. At the start of this product showcase, I stated that approximately 6,500 newborn deaths occur every day, with most of them occurring within the first week of life. Jens, maybe you could explain how Emily here can help address that.
Of course, with Emily, you can train everything that happens in the delivery room. No question. And she has a lot of features for that. So she has pulses on all four extremities. Maybe I stop her spontaneous moving, because it's a little bit easier to show all these things when she's not moving. And like in a real baby, it's also difficult to palpate the pulse in a moving baby. So she has pulses on all four extremities, of course. She has an umbilical pulse. You can even test a capillary refill time. So if you just push in this area, 3 to 5 seconds, and then leave it, you will see the capillary refill.
And
of course, you can change this here. So at the moment we have 2 seconds, and if you have a critical ill baby, we can change this to 4 or 5 seconds. And if you push again, you will see that the capillary refill is now longer. So, of course, you can place a UVC. You can, we did this at the beginning, you can do chest compressions. So you can do everything that happens in the delivery room, of course, but you can also do things that happens afterwards on an EQ. And I think what we clinicians are most afraid of, or something we are most afraid of, are, of course, pneumothoraxes. And this is something that's luckily very rare, but of course it can happen. And what we can do with Emily, with Paul, we were also already able to simulate a pneumo, but Paul was just so small that it was not possible to treat a pneumo. And so with Emily, we had a lot more space in the chest, and now we can simulate a pneumothorax, we can diagnose a pneumothorax, and we can also treat a pneumothorax. Yeah. And what we can do, and we can have a look on the user interface again. So if we want to simulate a pneumo, we unlink the two lungs and we choose the right lung, and we can simulate a pneumothorax. So that means if you put your hands on the chest, you will feel that the left chest is moving.
That's right. Right.
And the right chest is moving. And the belly is moving, of course. So it's hard to see.
Yeah.
And it's the same in a real baby. It's hard to see. Yeah. And so if we think this could be a pneumothorax, we have a very easy method to rule this out, or to be sure that it's really a pneumothorax. We just use a strong light.
Okay.
That's this one. You can use every strong light you like. And you can put this on the chest. It's called diaphanoscopy.
Okay.
So if you put this on the chest, you will see on the user interface, okay, the trainees check if it's a pneumothorax,
right,
with the light.
And I can see the red outline to show that
because this is the lung that's okay.
Okay.
But if they put it on the right lung, and normally you would dim the lights to see something on the chest, you see that there is a halo around the chest because there is a lot of air, no lung.
Right.
And that's the reason why this will be highlighted, and you will see a red halo around this light, and you can see the same on the screen here. So this is something how we can diagnose very fast, and if it's a life-threatening situation, it's necessary because an X-ray takes time, of course.
Right.
And if the baby is really in a life-threatening situation, we have to act immediately. Yeah, and so this is a possibility to be, pretty sure. Okay, this is a pneumothorax, and depending on the situation, we need to treat it immediately.
So in this situation, we put the light on. There's a pneumo. We saw the halo.
Yeah.
What do we do next?
For the moment, in this situation, I'm a little bit relaxed because we have a good heart rate, we have a good saturation. But if the baby is in a situation like that, I would not wait for the X-ray.
Okay.
I would sedate the baby, of course, and then place a chest drain. And we can do this today also, and show how this can be done with Emily. So you can do a needle decompression,
right?
But you can also place chest drains on both sides. So you have preformed holes, and actually this was a deliberate decision. Because to exchange skins, it takes time. It's you need to do it, and of course, it's a question of costs. And so we said, okay, spare the first step with the needle, skip this,
right,
and start with a dilator or with a wire.
Okay,
but don't put the needle in the simulator. And if we start with a dilator, for example,
so this is more, instead of trying to learn that tactile skin of the needle, this is more how to incorporate
the procedure.
To your simulation.
Absolutely.
Got it.
Yeah, so you can start with a dilator or just start with a wire.
Okay.
So and again, we are not sterile, of course. We have we are not gowned up. Yeah. So you can place the wire. Yeah, like you would do in a real baby. Take this out. Then take the pigtail catheter. If you want to, of course, we'll do this first, that we really have the correct steps. So you use the dilator. In reality, of course, you don't dilate it, because not in the simulator you don't dilate it because it's large enough, but just to have the right order of steps. And then you put the pigtail on it, and never lose this wire here in the baby. And then take the wire out, and you have placed the chest drain, and of course connected to the system. And what the instructors can do at the same time, if the trainees place the chest drain correctly, you click on the chest drain icon. You see that the chest drain is placed now. And by the way, all these actions and interventions go directly into the debriefing system. And if they did it correctly, you can, of course, open this lung, and then Emily's chest will move again on both sides.
And this whole scenario, it's that interplay and that dance between the trainees and, of course, the facilitator as you're clicking on the
because
computer.
I'm increasing now the saturation again.
Okay.
If they did it correctly, and also the heart rate, and normally, and also the ventilation. Yeah.
Very nice. Maybe we can talk a little bit if we go down the body. I know we've had a lot of conversations with our customers asking about IO access. Maybe you can tell us a little bit about IO.
Yeah, and Emily, it's of course possible to place IOs in the proximal tibia, in both proximal tibias, but already also in both distal femurs. So I think the distal femur will become a topic in the next years. As soon as we drill into the tibia in newborns, we might also drill in the distal femur. She's ready for that. Yeah, so you can do both. But for the moment, I think most people, if they use an intraosseous access, they will drill into the tibia. And again, we went a little bit a different way during the development, because I believe it's super important that the tibia is realistic. We need a accurate anatomy, because drilling into a tibia of a newborn is not a banality, because the bone is super tiny, super small. And of course, the fear people have by using an intraosseous access, or when using an intraosseous access, is that they drill through the bone. And so, from my point of view, we need a realistic bone in a simulator. And so what we did again, we used MRI scans, this time of the bone of term newborns. So this is an original tibia of a term newborn with the right diameters and the correct anatomical size.
Features.
Yeah.
So I'm just holding this. I mean, it's very nice, but it feels almost 3D printed.
It is 3D printed, of course.
Maybe you can tell us a little story about that.
Yeah, and this is, of course, also the idea, because as this is realistic, and as this is super small, you might need to replace it more often than you were used to in the past with other simulators. And so you need to replace this more often. And so you need a lot of these tibias maybe after a while. And so we said, okay, if somebody purchases Emily, you will get the 3D data, the 3D files of this tibia. So if you have a 3D printer, you can print it on your own. And if you don't have a 3D printer, we print it for you, and you can, of course, purchase it. But the idea is, if you have a 3D printer, you feel free to print it yourself.
And I like that whole idea. This is really encouragement for people to practice a skill, to drill in it, to make holes in it, and not have to worry about parts, because they're easily replaceable, because this is a skill that people should be training on. So very nice.
Should we do it?
Sure, let's go for it.
Good. So we have to turn Emily a little bit around, and it makes it take out the chest tube, because it makes me a little bit nervous if there's nothing connected. Yeah, so we can we take the left leg, just use something to put it below. So, and again, normally I would wear gloves, of course, and so needle. Need to turn a little bit more. Then we take the leg. What we normally do, and this is just my approach, what I do, I would just puncture the skin and feel where the bone is. Then I can feel the front side, the back side, and so this is the place where I should, or where I would drill, and then drill. And as soon as you feel a loss of resistance, stop the drilling, take the needle, take the mandrin or the stylet out, and you have placed an intraosseous.
And I guess that's why we talked about why this is so important, that this is MRI scanned and realistic, just for that whole movement where you felt the front, the back, just so we can be accurate and practice this as we would see. So, well, that's very great. Honestly, amazing, Jens, and I really appreciate you taking us through some of the features that be used in a NICU or in a critical care scenario. So, yeah, hopefully that gave everyone a little bit of insight into some of the features she can do. So Jens, we're coming to the end of this product showcase. Maybe you can tell us what comes with Emily or Emma.
Yeah. Emily and Emma come as a complete set, of course. So one of the simulators, Emily or Emma, is in the set, of course. You have the control laptop, the vital screen, it's a tablet, the stethoscope, of course, and everything comes in one box. Yeah, so that was the idea. We wanted to develop, again, a highly mobile system, especially designed for in situ training. Of course, you can use the system also in your simulation center and your nursing school, but the idea was, of course, to make in situ training, especially in situ training, possible and easy to train where you work.
And I love that idea that everything's contained in the same box, all your pieces, components, helps you not lose pieces, and just the efficiency of setting up a simulation. What should the viewers do next? Hopefully you found this intriguing. What should they do next if they're interested?
Of course, contact your local Laerdal sales rep and get more information about Emily and Emma. And we are all happy to present Emily and Emma to you on site. So just get in touch.
And we'll be sending you a follow-up email afterwards with this recording so you can view it again if you missed something or if you want to share, of course, with a colleague. And then maybe the last question, maybe a more fun question. We've shown a lot of great features today. There's a lot more. But if there's one favorite feature, what would it be?
That's a tough question, actually, because I like them both very much. I love how realistic they look like. I love their body movements. I love their airways and the realism of their airways. But I think for me, a super interesting and also important feature is the exchangeable airway, because this brings so many advantages, because we need to intensify airway training. I think that's key for the future. And you need a reliable simulator where this is possible. And even the youngest colleagues can train this without the fear that something, that you will cause a tear. And so I think my favorite feature is definitely the exchangeable airway.
And it's such a nice idea, the fact that we can exchange it out pretty quick, just in case there's a tear. They will happen, but it's able to do it and make it easy for the trainees. So, well, perfect. Thanks, Jens, for joining this product showcase.
Thanks, Greg.
And thank you, of course, to the audience here for joining us. And hopefully this session provided some helpful insights and information. We truly believe that real care, real decisions, and real impact can begin at training. And hopefully one day, we hope Emily and Emma can join your community and make those impacts. Thank you.